Okay.
Yeah, okay.
Okay. So very good evening, everyone. On behalf of IPN Kolkata chapter and IPN India, I welcome you all to a very interesting topic of discussion today. And we have very eminent speaker with us. So as you all know, we will be discussing on the autism spectrum disease, which is a broad range of condition characterized by many challenges. Especially patient is having repetitive behavior, skill development is there. So autism is the impact that impact the nervous system and affects the overall cognitive, emotional, social, and the physical health of the affected child or the affected individual. So obviously the nutrition is a very important thing, and the nutrition is also compromised for this kind of patient, highly compromised, because the patient is very much rigid, patient do not want to eat. So another topic, and I think ma'am will highlight that, is there any assessment or test? Obviously in the United States or the Western countries, there is some parent genetic testing which is done during the pregnancy. Another one is ADHD is one of the neurodevelopment disorder of childhood, and it is usually first diagnosed in the childhood part. So this is also it is responsible for a neurotransmitter that is non-epinephrine, which is synthesized within the brain. So we will discuss both autism and ADHD together. Along with, we have a case study also. So I am going forward to the introduction. I'm sharing the slide, requesting everybody except the speaker to keep on mute. Just let me know if the screen is shared. I will go to the recording. Sorry, I will go to the screen is shared.
Yes, Shaumendu, it is seen.
Okay.
It's visible.
So I am Dietitian Shaumendu on behalf of Kolkata chapter. Again, I am welcoming Dr. Mandira Roy. I am the life member of IPN. Dr. Mandira Roy is consultant development pediatrician. He has done his MBBS DNB in pediatrics from the Institute of Child Health, Kolkata. She has done her PG diploma in development neurology from CDC Kerala, assistant professor in Shantiniketan Medical College, consultant development pediatrician at Reborn Child Development Center, Asansol, which is also in West Bengal. She is the member of neurodevelopment chapter of Indian Academy of Pediatrics, associated as a faculty in state and national conferences and CMEs. So she has both national and international publications. And our second speaker, who is working under ma'am, she is dietitian Priya. She has completed her graduations and both masters and in nutrition and dietetics. She worked in Health World Hospital, Durgapur. She has completed a medical nutrition therapy course and presently working as a clinical dietitian at Reborn Child Development Center. So, ma'am, should I share your presentation? Mandira, ma'am, are you there? Just, Ifshita Di, I am audible?
Yes, Shaumendu, you are audible.
Yes, you're audible.
Slides are visible.
Okay,
Just
so
get it into slideshow.
yes, I am making, but ma'am is there.
Just a minute.
And okay, you just check Mandira Roy, Dr. Mandira Roy. I can see her. Okay. And before that, I want to thank Mr. Shashank from Signutra for partnering with us in this program. Thanks a lot. And now we are going forward to the main topic. There are few like live case studies also there, ma'am will share with us. So let us check, ma'am. I cannot see the screen. We need to check ma'am is there or not.
Can somebody call her up?
Well, you have her number? Okay, let me call her.
Yes, I'm calling. I'm calling. Wait.
Yes, ma'am has called me. Yeah, ma'am. Huh. Automatically. So now you are trying. So now you.
Dr. Mandira is visible, but no microphone is there.
No, Mandira Roy was left by mistake due to technical glitch. Now she has joined.
Okay.
Yes.
I think I missed a few things.
Yes, ma'am. The screen is visible. I am making it full screen.
Okay, okay. First of all, yeah, am I audible, right?
Yes, yes, you can continue.
Okay, okay. First of all, I thank IAPN for giving me this platform, and it's really overwhelming for me to see that so many people are so interested in neurodevelopmental disorders like autism, ADHD. And I thank Somendu sir for having me here. Also, Sanghamitra ma'am, I spoke with you, and Koel ma'am also, and after all, Priya, who like introduced me to your platform. So, first thing is that, can I stop my video for some time?
Yes, yes. If it is required, you can.
My video is showing.
Still, it is showing.
Okay, okay, then I'm not doing it.
You
Okay.
can continue.
So the first thing is that, yeah. So the first thing is that I would like to start it with one of my bitter experience. Is that around 2 years back, when I was like doing a research on autism, I was doing my thesis for the PG diploma that I did from Kerala. So back then, I came to know that one of the parents and their child, who was mild to moderately autistic, they were denied therapy because they did not stop the milk. So that means that the therapy person or whoever was involved with the care or the therapy, he was insisting on stopping the milk. Though the child was tolerating the milk very well, he was growing very well, he was putting on weight, but he somehow felt that this milk is making him hyperactive, and he insisted that if you come to me, you have to stop the milk. Okay. So from then only, I was like very interested in this subject and everything, that why they are doing it and what thought is coming behind it. So and why we are even discussing autism today. So, sir, next slide, please. Hello. Yeah. So today what we'll discuss is that that basic understanding of PhD. What I could gather from Shomendu sir is that he is like involved in care, maybe in autistic care, or a person with autism, they come to him. And there are many other who maybe you are dealing with autism every day, but there are certain among the audience, there are certain people who have joined today and they have not seen an autism case, or maybe they are not that much oriented to autism, like how it comes. And now that I'm in a place that I can tell of like obviously a few things about children, like mostly in the children, but adult part I will not be able to say. So I'm first of all, I ask for your forgiveness on that part. So what today we'll discuss is that basic understanding of autism, then basic understanding of ADHD, what it is and how it is, like what the way we see it. Then there are some dietary myths and facts that I will discuss little bit, and then Shomindu sir and Priya will discuss, and then we have an interesting case that we'll go through. So next slide, please. Okay. So why we are so worried? Why we are so worried that we are discussing it in a dietitian platform, or we are discussing in common general awareness, creating general awareness about it. So there are record-breaking cases that are being reported in last few years. I mean, in last 2-3 years, I would say, or maybe in the last decade already. that many cases are coming. So I think among the participants who have joined today, I think in last 2 3 years, or maybe around this COVID period and everything, you may have come across somebody who is either autistic, or somebody whose family that they have an autistic kid with them, and some discussion maybe have come to your side, right? So so the extent of families that are being affected. Autism is not a condition which affects only a child, but it actually affects the family itself. Like the whole family is somehow, it is either broken family, it is either dysfunction created by autism. So there is this extent of families that are being affected is very worrisome. Okay, now lack of awareness among community. Like if you say that I have a gallstone, then people will say that okay, you go to a surgeon and then get it operated. But if you say that okay, my child has autism, each and everyone will give certain kind of misinformation, I would say. So it is mostly flooded with misinformation. Even the online platforms are also, the social media platforms, they are actually flooded with misinformation regarding autism. So now lack of support services. We don't have good quality support services from, not say not like the government part, from the non-government part. So it is not adequate. Okay. And if we can diagnose it early, very early, then we can prevent the disability to a large extent with early intervention. Okay. So next slide. Yeah. So as we can see, obviously in India, we lack good quality data. So as we can see, the prevalence has risen like a steep rise in last few years. If you can see the graph, it is very steep rise, and it is in United States. And it is seen that 1 in 44 is the right now the prevalence is, and even right now as we are talking, maybe the prevalence is around 1 in 36. So 1/3 of the children, they are saying, is suffering from autism. Okay.
Again, I think doctor has removed, doctor has left, or yeah, she's there. Ma'am, you need to unmute. Yes, yes, you are there.
Yes, yes. Yeah. So now what is autism? So autism spectrum disorder. So it's a spectrum disorder. We have to remember it's like a spectrum of a light. I'll come to that later. So it's a spectrum disorder, and it's a neurobiological condition. That means there is biology involved, and it is a neurodevelopmental condition as well, which is characterized by persistent deficit in the social communication, in social interaction, and some restricted repetitive patterns of behavior, and some interest or activities. And there are many other symptoms that I'll come to later. So in India, currently, the prevalence we are thinking is that most of the studies that has been published, it is showing this prevalence of 1 in 100. But we know inside that this is not a correct thing. Maybe it is more than that. But because of less reporting, the prevalence is showing that it is 1 in 100. And we all know that male and female ratio is 4:1. So we'll come to next slide. Okay. So what causes ASD? So I think I got all the questions that you have sent, and that is amazing. Many, many questions. And I have tried to incorporate that in my presentation as much as possible. Maybe we can discuss it later if time permits. So the first thing is that genetic. Around 40 to 80% cases of autism has some genetic contribution to it. And the last 20% is mostly environmental. Environmental means there are multiple factors that are involved, both when the child is within the womb of the mother, and the antenatal period, and also in the postnatal period, and then in the later time. I'll come to that. Okay. And now a very interesting point here is the neurodiversity part that I will try to explain a little bit. So the concept of neurodiversity, because the first thing is that in the last slide, we must know that we don't know what causes ASD, what causes ASD or ADHD, this kind of disorder. We don't know its exact cause. That okay, this is the cause and this, because if we know the exact cause, then it will turn into a disease and it will have a treatment. But we don't know. So whenever we don't know something, there is a tendency in human beings that they try to hypothesize things. Okay, maybe this is that, maybe this is that, maybe this is causing something. Okay, so that is why there are many hypotheses are there, and it is largely involved in, and most of the things that have been like till date, whatever theory has come up for autism has not stand the research activities or the research studies. They could not prove anything related to one singular cause. So they have there are multiple things that has to be considered. Okay, so neurodiversity is one of them. So what it says that we all are different, right? So each and everybody. So just like that, we have a brain which is a neurotypical brain, or they call it allistic brain, and there is one another pattern which is an autistic brain. So that is a way of thinking, that is a way of conception, and I think it is coming in a big way. So now coming to the ASD, the clinical features. So one part is the deficit in the social communication. That means there will be a difficulty in social communication. It does not always mean, many people think that it means that the child will not be able to talk. It is not so. Even if he talks, maybe he will be less interested in other human beings. Maybe he does not understand the social pragmatics, does not understand the humor, sarcasm. So there can be some social deficit in part of communication. Okay. And there are some restricted, repetitive, fixed interested and patterns of behavior. They behave in a similar way. They have some repetitive movements, or maybe they do some kind of behavior which is repetitive, make some noise and something like that. So this is the mainly two uh, broad area of autism, and these two has to be there to satisfy the DSM-5 criteria that we use for the diagnosis. And you can see the circle below. It contains all the comorbidities that are associated with autism. So it can be associated. Now, autism never is, most of the time it's not alone. It comes with another thing. So you can see there is intellectual disability, there is anxiety, depression in later ages, then hyperactivity or impulsivity, which is an overlapping feature with the ADHD. Then there is can be associated with epilepsy, gastrointestinal problems, and many other things, sleep problems, metabolic issues, altered immune response to certain foods, sensory dysfunction. So we'll see that how much is relevant for us. Okay, next slide. Okay, so when the first thing we have to remember is that we have to diagnose it as early as possible. We have to recognize it, not diagnose. Even if we don't diagnose, but we have to recognize that there is a problem, and we have to do it fast. We have to do it as early as possible. So the first thing that we can see, even if we are very observant, we can recognize autism even in infancy, or maybe within 2 years of age. So there may be limited eye contact and facial expression. Remember the thing that this is a spectrum disorder. That means it's like a spectrum. It can be very mild and may be almost not recognizable, and it may be very severe. That may lead to a permanent disability. So we have to keep that in mind, and most of the child is in between somewhere. It may be very mild, maybe very severe, maybe in between. So we have to keep our mind open for that. Now, yeah, so we can see the video first. Now we can see, and then I will discuss this. Sound is not working, no?
Oh, sorry, my audio was off. That's why I think sound was not. Now it is okay?
So you started. No. No, it is, the sound is not coming.
Okay.
Okay, you see, I'll discuss it. Okay, so in the very first video, sir, please go back to the first video.
Yes, I am going back.
Ah, yeah. So what like run this video? I mean,
Actually, it is not
start this
playing.
video. Oh, some problem with that.
Yes.
Ah. Okay, so because the audio is not working here, so I can sum it up. So what we can see that is the teacher. She is one of very dear patient of mine. So we can see the child. The teacher is trying to communicate, with. See, she is smiling. She is trying. She is calling her, calling him by his name, and trying to engage him. But we can see that he is not making proper eye contact with teacher. He is not smiling. He is not making eye contact. He's mostly interested in the ball, but he just wants to take the ball from teacher's hand. I see the other child. Yeah, I took this video because it was like showing the comparison very well. Now, this is the child. See, this child, I called her by name and she just looked at me for 1 second and then her gaze is somewhere else, like she is looking somewhere else. And she's making these kind of lining up toys like this. This is a very classical feature of autism. They line up toys and cars like this. And mostly into her own world. She's looking into something. She's not all the time I'm calling her by her name, but she's not showing the name response well. Okay. So now coming to the next slide. Okay. So mostly autism is most about what we could see in the last two videos, that there are some form of social restriction is there, some form of social restriction, some form of repetitive activities is there, and other features. Due to privacy concern, I could not give much videos, but there are other features which is involved. We'll come to that later, mostly related to diet. Okay. So now what is ADHD? ADHD is again another neurodevelopmental disorder, which is the most common neurodevelopmental disorder. Okay, it is ADHD. I think one of you asked that why there is so much media attention or so much attention about ADHD. It is because this thing, that inattention and hyperactivity is, if we see a child, you will see that depression is one such thing that we use the term very often. That if somebody is he's very depressed, and oh, I got very depressed. So we use the term very loosely, though clinical depression is a discrete criteria. It has some discrete criteria, and depression does not mean only bad mood. Okay, so similarly, ADHD, we say that if some person is very hyperactive and not paying attention well, so we just use this term very loosely, that okay, you may have ADHD, but it does not mean that. First of all, in children, we have to wait for 4 years to diagnose ADHD, because before 4 years, most of the children are, in general, they are hyperactive and their attention span is less than 2 minutes. So we cannot assess that. Now, we have to remember that this hyperactivity, you will see that there are some kids who are very hyperactive at home, but they are doing very well in school or tuition or in swimming class or in other class. They are very good with others. In the outer setting, they don't have any problem. Okay, but when they are at certain only at home, they are maybe very hyperactive and doing all kind of mischiefs, right? So that will not be considered as ADHD. Okay, and now the significant derangement has to be there. Like the child is so hyperactive that his life is being, his life, he is not able to do the daily activities. He is not able to sit properly. He doesn't even sit for passing stool or urine. Like, so this may be a problem, and it causes significant problem in his daily life activities. And also parents are most of the time they are, how to handle this kid. I don't know how to handle this kid. So most often they beat them, or they, try to, punish them in a different way. Yeah. So next slide. Okay. So there are two criteria. So impulsivity, hyperactivity, and inattention. These three things compromises the diagnosis of ADHD. And there can be two discrete criteria. The child can be only hyperactive and can be inattentive. So these two types, or maybe mixed type, which has both. So in general, we see that children who are very young generally come with the hyperactivity type or the mixed type, and then as they grow up, they try to be the inattentive type. So what they do, they act before thinking of the consequence. You will see that the sense of danger is very lacking. If they go to some other kid, they will try to, the grab the child in so forcefully that they will not say, oh, I'll not make friends with you. So they run away. Okay, and then they have this tendency to interrupt others. Okay, and there is hyperactivity. Most of the time they are restless, their inability to sit, as I already told you, they are fidgeting.
Someone is on unmute.
Putting some
Please mute
background.
yourself. Audience,
Yeah,
audience,
yeah.
I'm requesting the audience, please mute yourself so that it should not distract the session. Yes, ma'am, you can continue.
Yes. So this is the thing that they are restless. Um, they are climbing on things. They are doing all kind of mischiefs. Okay. Okay. And then there is inattention. They have this forgetfulness. They go to school and forget about their pencil box or bag or whatever. Okay, they will not finish the work properly, which is given. They will not able to do homework, and most of the time they are lost in somewhere daydreaming. Okay, but in general, they don't have much problem with communication. So next slide. Next slide. Okay. Okay. So now I'll come to this slide, that is comparison between autism and ADHD. So first thing is that there are different kinds of overlap between these two problems. These two are neurodevelopmental disorders, and there is almost 50 to 80% of autistic children will be like it may happen that if we apply the test, they may come to be positive for ADHD. And similarly, if we test the ADHD kid with the autism test, so maybe they will come positive for that also. So there is a great overlap between these two conditions. Okay, but here I have concentrated with the some noise is there, background noise.
Let me just
mute. Shaumendu,
yes.
Request you to mute everyone except Dr. Roy.
Okay, okay.
This is very disgusting.
Obviously. I think now it is okay.
Yeah, otherwise I will not be.
I'm sharing the screen once again. Yes, ma'am, you can check it.
Okay. So now we are, so what we are saying that there is a great overlap between ASD and ADHD, but here we are mostly concentrating on the difference, like how to differentiate. So as we we could see in the last video, though the sound was not there, but we could see that I was calling them by name, and the name called response was not proper. Okay. So the social reciprocity was not good. But in ADHD, the typical response to name, and they are attentive, like, okay, what is happening? They will be attentive to you. Okay. Okay. Then limited facial expression or gestures, poor eye contact. So this is a part of more like ASD, but they have different kinds of expression. Even they are good to talk. Sometimes they talk so much that even their parents are even in problem for that he speaks so much. Okay. And typical eye contact. Whenever you, most of the time, they have typical eye contact unless and until they have great anxiety for which eye contact may be less. Okay, then repetitive behaviors mostly seen in autism, but less seen in ADHD. Okay, then peer interaction problem, we have to see that there are two. There is a clear difference between how ASD person relates with peer. So mostly they have this avoidant personality that they don't want to interact with others, or they avoid the social communication, the verbal communication. In ADHD, it's mostly the opposite. It's like they cannot control their impulse, so they will go, they will somehow disturb the other kids, and so that's why they will not take it. Okay, so there is two discrete way that they relate to peers. Okay, next, because I think I had some one video. Okay, so this is a child with ADHD. You can see that I'm talking to him. I'm saying very funny things to him, and he is smiling. He is interacting very well with me. Though he has some fidgetiness, you can see that he will be moving his head. Uh, he is making some. He is acting like what he does at home. He is showing me that okay, I act like this and disturb my parents. So he is very conscious about whatever he is doing. He is very aware. Okay. When I asked him that why you came to me, he said that I do all kind of mischiefs and that's why my parents have brought me here. Okay. So yeah, but he is interacting. He is interacting well. Anyway, we'll go move ahead. Yeah. So what to do now? Now I think I have given a very basic idea of what is autism and what is ADHD. So what to do now that like what you can do, like if you see somebody that he has some problem, you notice and you ask the parents like, do you notice some problem with it? Do not utter this term of ASD and ADHD if they are not already diagnosed case. What will happen? Most of the parents, they are in denial in this situation. They will not accept this and they will also not come to you. So first of all, do not use this term, both term. What you can do, you can suggest, okay, I think that he has some, he's not always, reacting to his name. I think he is not looking at me well. So does he do that at home or he's doing it with me right now? Okay. So you have to put the doubt in their mind that there is some problem is there, and let them go to their pediatrician and ask. So what we can do, like if you suspect autism or ADHD, any kind of this kind of things, or any other neurodevelopmental issues, then you refer them to a pediatrician or a developmental pediatrician or a pediatric neurologist or a child psychiatrist. These are the people, these are the doctors who can diagnose the ASD and ADHD and give a proper plan. So then they will do some developmental and specific assessment for autism and ADHD, and then they will create an individual therapy plan. Okay. So next. Okay. So assessment tools. So somebody asked me, asked in the questions that is there any blood test or is there any specific biomarkers for it? So there is no biomarker, neither for autism nor for ADHD. Evaluation is mostly by parent interview and behavioral observation. And if the child is like
again somebody is on unmute. As I cannot see the thing, yes, now she has muted. Miss Shushmita Moitro, you are getting unmuted repeated times. This is my earnest request. The session is getting disturbed. Okay, Dr. Roy, you can continue.
Right. So then we have to assess the functional level. Okay. You will be getting many questions like if you deal with autistic like autistic children or adults, that what is the level, what is the functional level, or they say mild, moderate, severe. So we see functional level, like how much he is functioning according to his age, or what are the daily life activities he is able to perform, how he is mingling with the peers, how he is going to school, how he is behaving in school. So these kind of things that we see for functional level, and we do proper assessment for autism. Like they have proper assessments like CARS, Then for ADHD, we have Vanderbilt and then Corner's test. So we do that for a proper test, and we get multidisciplinary help from our child psychologist or whoever is there, clinical psychologist, and then we get that. And remember one thing, that a developmental assessment is must in few age groups, like from 18 months onward or even maybe 12 months onward, they must have one developmental assessment done by a specialist, and to detect it early, to screen for autism. Not only the diagnosis will be later, but to screen for autism. And we can screen for autism since 16 months of age, which is very, very early. And if we get something in the in chat at 16 months, we can do a lot. Okay, so next slide. Okay, so this is a part of my study that I did, and the comorbidities that I could record. I kept it here because we can see that 26.5% of children, they got this GI problem or gastrointestinal problem. Okay, so this is one thing. Though I think this is less. I mean, the percentage should be more. Like almost 40 to 50%, they have some kind of GI problem. And another thing that I want to show you is that, see, the 10% of children also has. This is a study on ASD, but the 10% they have ADHD also. So autism and ADHD, they can exist together. Okay, they can exist together, but we can only prove it later, maybe after 5 6 years we can see, not in the early phase. In the early phase we have to treat it like autism. Okay, so next. Okay, now principles of management. I hope that you can see the slide because it's very little things. Okay, so the first thing is that it is a multidisciplinary approach. It is always many people. It's not only me that I will diagnose, I will treat and everything, but it has to be a multidisciplinary approach, and where parents are also involved. We have to involve parents also, right? So we have to do that. We have to like go for the core features of both autism and ADHD. We have to do something for that. And then there are different kinds of therapies like occupational therapy, sensory integration, then special education, then speech therapy, then many other therapies which are combined in a particular way. And always remember that if you have seen a child with autism, you have seen one child with autism. So each and every child's plan will be different. It will be an individual therapy plan. So dietary management, then anticipatory guidance, then some cases need medication also. Okay, and obviously inclusive education in the later part. Okay, so now we go. Yeah. So what is the future direction? So we can see that this is the CDC. CDC is the Child Development Center, and it is very well. It is depicted that this related to medical specialties, then family, the child, the school, community, and everything is done together. So everything comes together. You people, obviously, all the fraternity, all medical and non-medical, whatever, like fraternity is there. Everybody has to come together because it is such a condition. It is almost like a condition of epidemic. Okay, and we have to remember the transdisciplinary model. So what is I will just give an idea like what is this transdisciplinary model. It means that two separate specialty, but there will be an overlap and there will be a mutual feedback. So that means that both myself and Priya, we work together, and if that some, it's not that okay, you go to this dietitian and you do this diet management and all. No, each and every step we are in a feedback loop. Like Priya is trying to establish the feed, and maybe she discovered that okay, the feeding problem is not at all due to food intolerance or some food allergy or something like that, but it's as simple as the child is not able to chew the food properly, and maybe he has some kind of sensory issues. So this feedback is very important for me because then I have to tell them that you have to do some oromotor sensory activities to, decrease the sensory hyperresponsiveness and feed well. So in this process, we are involving, the doctor is involved, the dietitian is involved, the occupational therapist or the sensory integration specialist, they are also involved. Even the speech therapist is involved. So all is coming together to solve a problem. So this is the basic of my transdisciplinary model. And we have tried to implement it and we are doing it very well. Next is biopsychosocial model. So it says that when we are dealing with autism or ADHD or something like this kind of neurodiverse conditions, our focus becomes that the child is a patient. I think this is our problem, or I will say that our system's problem, that we see a person as a patient and not as a person. So in this way, but we have to take care of it because it's a long-term condition. It is not something that, okay, for 3 months you do this and then you will be fine. If a person is autistic, he will be autistic for life. So we have to take into consideration everything, that whether the family is good, is there any family problem, okay, how the parents are doing. Most of the time we are seeing that both parents are working, then how they are managing their stress. So it takes a lot. Okay, so you have to consider all the aspects, not only the, okay, he is a patient and chalo isko therapy kar do and then ठीक हो जाएगा. So ऐसा नहीं. Now, parent-mediated home-based intervention, because obviously the load is so much. Patients come from so distant places, even from Bihar, from Jharkhand, from so many places. So we cannot give a center-based therapy to those patients. So we have to offer some home-mediated, home intervention, home-based intervention to them. So this is the future of the direction of management of ASD and ADHD. Now, next slide, sir. Okay, now I'm coming to a portion where you will be interesting, like it will be interesting for you. So what are the problems that we get in general? That is GI problems, gastrointestinal problems like constipation, very common. Gastroesophageal reflux, which is also very common. Diarrhea, abdominal pain, which is non-specific, and it is for all the children. All the children, they complain abdominal pain, be it autistic, non-autistic. Then celiac disease, definitely gluten sensitive, celiac, non-celiac, both kind of. Then food allergies, food intolerance. And there is one interesting condition, I think it calls ARFID, that is avoidance and restricted kind of this feeding behavior. So this is a name they suggest with autism. Okay. And what are the diet related problems? We can see that from the very beginning, when the baby is a newborn baby, is while breastfeeding, not looking at the mother. Normally, the attachment is not good. It's not able to feed at all. Okay, so there is poor attachment. He's crying. Okay, difficult weaning. So remember, these children have a tendency to being fixated to some kind of food. So once this child is or the baby is fixated to breast milk, then it's very difficult to wean that child from breast milk to solids. Okay, then difficult chewing because of this related to muscles and related to also the sensory part. They are not able to chew, and also because they don't talk much, they don't try to talk, they don't initiate communication. So obviously there is problem around the mouth. They have some sensory issues also. And picky eating, obviously, it's a very big thing, and that leads to malnutrition. And malnutrition doesn't always means underweight; it also means overweight. So it can be both ways. And sensory problems and interoception. Interoception issue means that they have this tendency to not being aware of their hunger or satiety, both. So when we have this hunger, we know that we are hungry, but they are not able to express that, or maybe they don't always process that in a proper way. So they don't know when they are hungry and they don't know when they are full. So this also creates a feed problem. Okay. And always remember one thing, that having food is a complete sensory experience. We have all the experiences. We see food, and we always say that, just by looking at some food, okay, say golgappa, we said, oh, I have to eat this. So it's just every vision, this, then you say that what you are eating, and maybe you listen to it. Okay, and food being cooked, there are many people who said that while cooking, the sounds of cooking make them, salivate. Okay, that okay, very tasty food is cooking. Okay, and then obviously taste and smell, very very important, and also the touch. They do touch the food texture, particular texture. They touch within the buccal mucosa, and they create a sensation. So food is a complete sensory experience. So now I'll come to the next slide. Okay. So this is a burning thing now. Meal time or screen time. Okay. And next slide. Okay. So I think the pictures that I shown you, I think this is some very frequent we get this kind of problem. Most of the children nowadays, they always with the mobile phone. They are always with the smartphone. And a very good study has been done in Japan. They have proven that idle screen exposure at 1 year, I mean, from infancy, have a significant contribution in developing autism at 3 years. Okay. So at 3 years, they have studied that more than 2 hours of screen time at 1 year has led to autism-like features and autism, and they have proved it. For the long time, we are not sure, but now they have proven it. Okay, so boys are affected mostly. Yeah, we have already talked about this. Then there is this term which is going around in the social media as the virtual autism or autism-like symptoms. And passive screen time is what? Passive screen time means that time there is no human interaction. The child is idle with the screen, and definitely it has some role, and there is this role of pandemic on it, and social restrictions were there, so children mostly got exposed to screen from a very very young age. Yeah, so next slide. Okay, so good food is good mood, right? So if we eat well, then definitely it will affect our mood well. So, and it is same for everyone. It is same for us. It is same for autistic kid also. Next slide, sir. Okay. So now I'm coming to the part where I think most of you want to know. But I tried to took it in a different way because I thought that I will not be spoon feeding that what is right and what is wrong. Rather, give you the idea like how to think about it and how we think about it. So what is CAM? CAM is a complementary and alternative medicines or health practices. So this is again the diverse group of practices that are done. This includes the health practices as well as medicine as well as some foods. Okay, so it is perceived as natural, and you will be surprised to know that at least 80%, more than, I mean, this is an old study, but now I think almost 80% of parents or the families, they use CAM. And this can be anything. This can be yoga, this can be meditation, this can be martial arts, and GFCF diet, ketogenic diet, vitamin supplements, and all kind of things. Even stem cell therapy, even different kinds of heavy metal chelation. So all are included in this segment called CAM. Next slide, sir. Okay, so why they use CAM? So first thing is that hope for cure. And in everyday practice, what I see that there are some uh, different kinds of food supplements or different kinds of activities, they claim to cure autism. The problem starts there. Okay, they are telling people that okay, you have this and it will cure the autism. So that is the problem. So that's why their CAM become a scam, right? So that is mostly suggested by family and friends. Okay, so they have this tendency. It looks like natural, and media influences, which I am telling. So if there is one video that has got millions of views, and obviously that will affect people. And perception of safety is also somewhere because they think that maybe Ayurveda is safe, maybe homeopathy is safe. maybe whatever we are doing, this kind of food is safe. So this perception of safety is also very important. Okay, then personal beliefs about health. So there are, we are in a land which is very, very old. We were used to Ayurvedic medicines for a long, long time. So that effect stays, they use these terms called, hot food, cold food. So these are there. So it is the cultural belief also. So these are the reason why they go for this camp. Okay, next slide, sir. Okay. So now what we'll be thinking of is that whether we should accept camp or we should not accept camp, and how we'll make the decision. So first see that level of evidence is the main thing that we have to see here. And evidence means scientific evidence. So as we can see the pyramid, see that the case studies and expert opinions. So that means like I have managed 1,000 cases of autism and I have used a particular drug or maybe a particular food. And can I say that, so maybe in thousands of cases I have used card and I have found that there is some improvement with cards. So can I use card and can I say that card is helpful to cure autism? No, right? Absolutely not. So obviously we have to consider these are the least evident thing, that case studies and experts, and you will be surprised to see that whatever these all fads of foods or whatever is being shared everywhere is mostly based on this lowest most evidence, that there were some parent or some family who use this particular thing, particular food or restricted food, and then they perpetuated this idea that okay, my child is doing well. Okay, but you cannot believe this because there are many other things are going on. The child is also on therapy, the child is also on maybe other medicines. Okay, so only being pointing one thing that okay, this causes improvement. So whenever you get to know about something, because I know that every day some new thing is coming. Okay, initially it was GFCF diet, then it became soy free also, so GFCF soy SF diet. Then someday it will be like a ketogenic diet, and someday it will be like a paleo diet. So each and every day some new thing will come. Okay, but what we have to look for is whether the study is good evidence, whether that thing has good evidence or not. So good evidence means systematic review, and most of the studies that I went through, I have seen that there may be 500 studies done on that particular topic, but when they go for systematic review, only 5 studies actually qualified for the good quality studies. So we cannot be very trustful about that. I read some report that they did like a study on 17 kids for ketogenic diet. Someone asked in the group. So they took 17 children and all improved. And also, the funny thing is that all the children they have epilepsy. Okay, so it is already proven that there are some kind of intractable epilepsies that are the ketogenic diet is tried there and they have got good reports. Okay, so if it is associated with epilepsy and autism, then ketogenic diet, that is fine. Okay, so but we have to go through a certain process, a certain specialist opinion for that. I'll come to that. Okay, next slide. Okay, so diet scam are like I've already told all this that most of the dietary restrictions. Okay, so according to the evidence, we can grade them like grade A evidence, grade B evidence, grade C evidence, grade D evidence. So most of the dietary restrictions and supplements they fall into grade B evidence, which means that there were some behavioral improvements are reported, but in some kids, definitely in some kids, it there were some improvements, maybe in stereotyping, maybe in core behavior, but it lacks conclusive evidence to apply to all children. Okay, like I told you about my experience that the therapy center or the therapist was like so vehemently, no, you have to stop it. So we cannot do that. Yes, definitely there are certain, if autism is increasing so much, then obviously there are autistic kids who are also having severe disease, who are also having CMPA. Okay, so we have to restrict it for them, obviously. But it cannot be that, okay, you are autistic, you will go to GFCF diet. Okay. So can be used as an individual therapy for patients with particular disease or proven problem like gluten sensitivity. We have to prove it that yes, he has gluten sensitivity. Okay. Milk allergy, yes, we have to prove it. Soy allergy, you have to prove it. Okay. So without proof, without anything, we cannot just stop these products. Okay, because that will lead to nutritional imbalance. Okay, and definitely under guidance of specialists. Okay, definitely, because what happens, we stop them for, maybe somebody stop them and tell them that you give GFCF diet. But what about substitution? What about the nutritional substitution that is not being done? And they are suffering from it. They are losing weight. They are not getting the adequate nutrition, also the micronutrients. Okay, so definitely under guidance, obviously under some dietitian, we have to do this. Okay, next slide. Okay, so some question that we should ask for deciding whether we should allow any CAM along with our conventional therapy is that first and foremost, is it safe? Okay, is it safe? So if I'll come to that, like how to decide it. So is it safe? Is there any trained specialist involved? So if some therapist person or some doctor or anybody is stopping the food, certain food, is there any dietitian involved in that care? Whether he has gone through the case. Okay. Okay. Is there any genuine improvement? So it happens that they stop it and there will be some timeline, right? Maybe you stop it for 3 months, maybe for 4 months and 6 months, but for lifetime, they are stopping it for lifetime, and maybe there is no improvement. Okay, so is there any genuine improvement? Can it be proven? Okay, so if there is improvement and then I stop it, so there may be deterioration because most of the allergies and most of the intolerance cannot be proven by a blood test. So we have to do it clinically. So can it be proven? Can we prove it? And is there any scientific evidence? Is it in some peer reviewed journal? What is the funding of the study? Most of the studies, they are funded by either by the pharmaceutical company that is they are producing the drug or producing the medicine. There may be some supplements company and maybe they are funding the study and that's why they are showing improvement. So we have to take everything with a pinch of salt. Okay. So is it relevant to the child? I don't know whether you seen this or not. There was one report that was going on during COVID period that a child who had a very bad food allergy and they were only sustaining on the camel milk. So the child was quite like it was not in the infant stage. I don't know whether they were not giving him solids, but he was only sustaining on camel milk. And the mother was traveling by train. So she requested the Indian Railways to provide the camel milk for her child, and they provided. Very nice of her. But why it is so? Why it is so? And after that, there was a boom of camel milk production. And already many companies have come with camel milk. I don't know whether they contain camel milk or any other thing. But is it at all relevant? Camel milk can be relevant in Rajasthan, but how it can be relevant in Bengal? Okay, so I don't know. Now, media gimmick. So, is it at all good, or it is only a media gimmick or some business plan? Okay, and is it cost effective? Is it somehow cost effective? So that we have to see that the family who cannot even afford therapies are trying to go with some this kind of food. Okay. So now I have made this 2 by 2 contingency table for all of you. So decision making is that if it is safe and effective, we can use it. Okay. If it is safe but not effective, obviously we'll restrict it. We'll talk with the parents, we'll talk with the family, we'll have a good chat about it. that why it is, we'll talk about them, about the evidences and all, and we'll try to restrict it. If it is not safe, then definitely, but it may be effective. They are saying that this is effective, then limit it. Okay, that okay, you use it for 1 month and then come back and then stop it for 1 month and then we'll see whether any deterioration or not. So we have to discontinue it. And it is not safe and not effective, obviously we'll discard it. Okay. So this is how I think we can take the decision about the camps. Okay, next slide. Okay, so the take-home message is that ASD is not curable. The first thing is that it is not curable, but it can be made indistinguishable. So what does it mean? It means that at the, like, if we start early, if we give the proper intervention, then maybe at 3 years or at 5 years, the child may look totally fine, may look like other kids. You cannot differentiate it. You cannot distinguish them from the general population. So that can be done. And someone asked about reversible. So I will not, this is reversible. What is reversible is that there is some entity called early screen exposure. Okay, so if there is I already told it. So there is one condition called early screen exposure related to this autism. So they have this feature of autistic-like symptoms, but their origin is screen-induced. Okay, so if we stop screen, these children dramatically improves in 3 to 4 months. Okay, and almost to an extent of reversal. So it looks like they're in reversal, and we don't know. Maybe we can follow them, and this is like happening very recently. Okay, and what is about the other condition? Like there is genetic predisposition. The child is maybe mild autistic. Maybe by 3 years or 5 years, if we do the proper testing, tests may come negative for autism. But that does not mean that they are not autistic anymore, because their brain is made like that. Their brain is formed like that. Okay. So it can be in remission, but we cannot say that it is totally cured or reversed completely. Yeah. So early recognition and early intervention can prevent disability to large extent. Always look for the evidences before applying or restricting diets that I have told. Now you can be an agent of change for the families. Yeah. So I think that's all. Thank you so much. I think I have tried to cover most of the questions, but I think there are different questions which are left. And now
I
Priya
think most
has
of the
some
questions are being shared. Maximum things you have covered, and it is really a nice presentation. So Priya, ma'am has covered everything, mostly everything. So whatever the case study or you want to emphasize on the balanced diet, you can go ahead. Okay. Priya, the screen is shared.
Am I audible, sir?
You are audible, but
Okay.
we have crunch of time, so at least 10 minutes
Okay.
we have.
Okay, sir. So good evening, everyone. Till now, we came to know all about the autism and ADHD. Now let's know about the diet. Sir, now let's all about the diet for special child. Okay, the question is there any specific diet for them? It's a controversial topic. Ma'am already discussed about that. So actually in our practice, we see that no, there is no any specific diet for autistic children. So that the fact is a balanced diet is prescribed or preferred. Whatever diet present in the market like paleo diet, specific carbohydrate diet and Feingold diet and so on are not scientifically proven. So for the safe side, we can rely only on balanced diet, which is not then more than useful than any specific diet. We can achieve our goal by prescribe this. And what is, sir, previous slide, sir? And what is GFCF diet? Also there is, sir, previous slide, sir. Yes. So what is GFCF diet? There is also a wrong notion among the people. The children who have autism can only have gluten-free food or in any casein-free food, but there is not significant research as such. Firstly, need to know who can actually have gluten-free diet or foods. People who are suffering from celiac disease, ma'am already said that, celiac disease or any gut related issue, or after having wheat and wheat product, for those only prescribe gluten free diet, and who have only lactose intolerance or constipation, for those we can only prescribe casein free diet. Next slide, sir. Okay, sir, am I audible? Hello.
Yes, yes, kindly continue. Thank you.
Okay. And what is a healthy diet? Actually, healthy diet contains all type of nutrients that nourish our body. It includes good healthy foods, provide a balanced diet. It does not contain any, sir, previous slide. Yes, contain any processed food. A balanced diet does not contain any processed food. It mainly comprised of good fats like nuts, seeds. Next slide. So, what we can add? The big question is, so what we can add? You can see in this slide, we can add complex carbs like whole grains, vegetables, and fruits. And in protein, it's a general common question. In protein, we can add high biological value protein like fish, which contains omega-3 fatty acid, paneer, as for example. So next slide, and vegetables, fats, and vitamins also. And how to introduce, the question is how to introduce new foods. It is also seen that in autistic children may not prefer to try new foods. So how we can make them habituated with that? If we make them sit with another family member and make meal fun, and with play factors, we can introduce with new foods. Next slide, sir. Okay, the nutritional concerns for the nutritional concerns for the autistic children, that is that we know that they are very picky eater, they're rigid with their routines, they also have sensory issues and allergies, and they also may have high rates of gastrointestinal disorder. Ma'am already discussed about this. Okay, sir. Next slide. And what we can add in dietary modification, we can add antioxidant like broccoli, spinach, magnesium rich food for their cognitive development, folic acid for their cognitive development, calcium for their bone and teeth formation, like milk. Next, and make them mealtime routine, their positive mealtime routine. Meal and snacks should be given at the same time every day, because they're very rigid with their routines. No other, please don't give them drink in between meals, and habituated with them with appropriate sitting and eat meal together in so next slide. What should not be given them? Chocolate chips, we all know that the chocolate chips, cold drinks, packet food, sugar, please try to avoid this. Now came to the case study. Sir, am I audible?
Yes, yes, just it is the last 5 minutes we have, so
Okay. So video off now.
no issues, you can continue with
Okay.
it.
Case now came to the case study. First, this is the patient data. Her name is Adya Prakash, age 3.3 year. Her height is 85 centimeter, weight 11 kg, and we are seeing that her BMI is 15.2 kg per meter square. So next slide.
So we can see both height and weight is not up to the mark. The weight should be at least more than 15 kg. And we find that always this kind of children, we should plot in IAP growth chart. Below 5 years, we do in WHO, and above 5 years, we plot in IAP growth chart. And we have to maintain that growth chart every month when the patient is coming to us. Yes. This is the chief complaint you have written.
Yes. Firstly, this is a cheap complaint. When her mother visited to our center, Revon Center, that time baby was only on liquid and smashed diet, and small quantity of
Sorry, by mistake.
small quantity of smashed food. She was on the above diet and she unable to chew anything. She was only on liquid diet and her mother gave smashed food, as mother main concern was to fulfill the baby's tummy. Next slide, sir. Actually, the case study, and on observation, we all seen that the baby was on small stature with lean body mass, and baby came to our center by walking with normal gait.
So this is a very difficult thing I have seen, that the baby is given milk and smashed chapati and milk. If we see, Priya, sorry for my interference. So because it is a very interesting thing for the audience, if you see the child is going to bed in 5 a.m. in the morning, almost the entire whole night the child is awakened, and the child is taking only liquid and smashed food. So how the enzyme will work? It is at the age of 3.3 years or 3.5 years. So now, Priya, I am changing the slide.
I have taken the child's diet recall from her mother. Okay.
So you can just tell us that how you have changed the habit. It is very important that changing the habit.
Management.
Management. So it is obvious, ma'am has also shared that obviously there will be severe constipation. Dietary fiber is very less. Oral sensory, that is chewing issue is there. So mother's main goal is to fulfill the tummy.
Exactly.
Yes, now you can just
and
continue
now,
the management.
Now came to the management. Actually, the baby was only on liquid diet and her sleeping pattern was very bad. She used to wake up at 11 a.m. at morning. In previous slide, we've seen that after she used to drink 150 ml of milk, she only 150 ml of milk and no other any solid food. And after waking up, now came to the management. Now I correct her sleeping. Firstly, I correct her sleeping habit as per instruction her mother to sleep within 10 a.m. In diet modification for the time being. Instead, I suggest her to give some semi-solid food to initiate her achieving habits. For example, I give her smashed
finger foods.
Yes. So boiled soybean, boiled carrot, boiled cucumber for initiate her chewing habits. Next slide. Achievements. After that.
So this is that improvement. This is a great thing you have done. The child is now taking this meal. This is not the prescribed diet chart,
exactly,
but it is mostly modified diet chart, which the mother is now following. The mother who is only taking milk and smashed chapati with milk, and now the child is having nutrition supplements, almonds, dal, pulses, vegetables, fruits. So different way the mother is trying to present, though this is not the actual diet chart which is given by Miss Priya, but this is what the timing has been set, if you can see. So it is a great thing. Priya, just can I show the video to the audience? Sorry, it will not be played. Child is eating on her own.
Exactly.
When the child is given smashed food only, and it was force-fed, maximum time not
improved drastically. She has changed.
ADHD, maximum normal child is force-fed. That's why the rejection comes. So now the child is trying to eat.
Now she is eating to her own self, and her chewing habits also improved.
But unfortunately, I think the sound is not there, Mandira ma'am. So we cannot share the mother's feedback. We will share the feedback. We will share the video if it is permitted, then to our members, IPN members. So it is a fantastic feedback given by the mother about the child. Is it audible? Anyhow, it is not play. Is it audible?
No, it is not audible. No, it's not audible.
Not audible, sir.
You can share in the group, not a problem.
So
I think
she,
if Priya has taken the permission from
Yes, ma'am. Yes, ma'am. I've taken
the mother,
her permission, ma'am.
so she has already taken the consent, and I think for educational purpose, you can see it.
so Priya, it is your last slide. You can wind up. Then, if we have, we will invite Ipshita ma'am to take some questions.
Okay. Okay, sir. Okay, in this slide, we can see alone a dietitian or a doctor cannot treat ASD or ADHD. If should be it should be a holistic approach. In a team, we have to treat the patient, counsel the patient, and take help of the other like speech therapists, like occupational therapists, like special educator, like psychologists, audiologists, as well as, sir.
Yes, it is very important.
And takeaway message is investing in early childhood nutrition is a surefire strategy. The returns are incredibly high. And thank you. Thank you, everyone.
Thank you, Dr. Mandira Roy, and thank you, Priya. It is very practical scenario you have presented. I like to invite our EC member, Ipshita ma'am.
Thank you, Shomendu, and thank you, Dr. Roy and Priya, for such a beautiful presentation. But I don't think we have time left for questionnaire because time is still 9:30. It's already 3 minutes past that. So, if is there any question? Because I couldn't find anything on the chat
I think
box.
GFCF diet asked by senior dietitian, it is covered. GFCF diet is restricted to some of the patient. It is not for all patient. And if the patient is having milk protein allergy like casein protein, then only. Otherwise, some patient are having, Ipshita ma'am, you will agree with me that constipation is a issue. So giving too much of milk.
GI disorders are issues.
GI disorders.
So instead of milk, we can give curd, or homemade curd can be given, or in a different recipes. Totally just no need to stop casein. You can give millets in different form, but main thing is in different way we have to present. And keto diet asked by Miss Khushbu it is also covered by ma'am. So it is also not for all patient. So any other one or two question you have in the?
I think I'd like to add something.
Boys are affected more than
Right
girls,
now,
and it is also covered. In the chat box, it is written, the boys are affected more than the girls. Ma'am has already covered.
Yeah, so I'll just quickly, I will add something. I think last few questions that Priya shared.
Ma'am, you can also highlight about the test. Dr. Mandira Roy, if you can highlight about any test.
What I want to say is that people are asking that why boys are mostly affected. So there were many studies done and seen whether the X chromosome is mostly affected or Y chromosome, is there any relation with that? So if there are certain syndromes that are associated with autism, so like Fragile X, maybe a tuberous sclerosis, maybe some other Prader-Willi syndrome. So some syndromes that are directly associated with autism, they may have a proper genetic root. Otherwise, even if the condition is genetic, but the yield is not very good. That means if you try to test it in a any child, then the yield is less than 10%. Okay, so there were some people who were trying to tell me, asking me that it can be detected in the pregnancy time. So there are not good scans like Down syndrome or so, but we obviously advise people to go for genetic testing. If they have one child in the family who is autistic, then if one child is autistic, then the percentage increases, the risk increases a little bit, around 4%. But if there are multiple cases, then the risk increases up to almost 20%. So that is one condition where you can have a test. Genetic testing antenatally, so that you don't affect with autism again. So this is one thing. And genetics, I think I did not go much about it because there are various people. I mean, there are students, there are teachers. So I thought that it's better to keep it very basic. And about testing is that testing, the first thing is that MChat is the very easy test to apply in any child. Even if you think that you are suspecting something, or maybe in your family or in your known people, then MChat is a screening test for autism. I think that can be done by, that is actually parent interviewed, so you can anybody can do that. MChat for early diagnosis.
Thank you. So the question which we cannot take, we will send you, Dr. to Mandira Roy. And most of the questions, I think it is answered.
Yeah, sure.
Okay.
Yes.
Most of it has been
How
covered,
to
which is
increase
being
vitamin D3
Vitamin D also, I
And,
think, Dr. Roy, it will be same for the other children. Most of the children are nowadays
Same
vitamin
for-
D deficit. So either you
Yeah,
prescribe that in a weekly basis supplement form, that is D3 drops or syrup, and obviously exposing to
Syrup.
sunlight and vitamin D rich food should be given.
yes.
If anything more you want to add, you can just add on.
Along with calcium and phosphorus, obviously, we have to keep that.
Okay. Okay. So, okay. Okay, Ishita ma'am, you can just give the vote
It's
of.
better to keep everything natural, the packaged food and the colored and flavored food to be avoided for any kind of, we don't know what we are eating on those things, and toxins definitely. Okay. But probiotic is coming in a very good way.
Probiotic,
But
yes.
it is not
Probiotic,
as,
yes.
yeah. But probiotic is coming in a big way, but it is not as simple as that supplementing it the way we do. It's not only lactobacillus or something. Lactobacillus reuteri is coming in a big way. But yeah, maybe they can go for, fecal microbiota transplantation and everything like that. So yeah, it is coming. Just keep an eye on autism. It may be coming with a very good results. So some studies are going on.
Before I say my vote of thanks to everyone, I would ask only one question. Lekha, you are dealing with children only. Do you have any inputs, anything to say about this?
Yes. Ma'am is from Chennai, Apollo, Pediatrics Chief Dietitian.
Oh,
Yes, ma'am.
Thank you,
okay.
Ipshita, for giving me the opportunity to speak over here. Wonderful talk, Dr. Mandira. I really appreciate the way you have handled it. We do also follow the same thing of going with the balanced diet, but the challenges where we face are, especially when they are undernourished or overnourished. Overnourished, there again, how to, like, as a dietitian perspective, to make them okay with the diet is little big challenge what we face most of the time. And same way is undernourished. So there, otherwise, it's the same. The balanced diet goes with the same thing. I don't go with giving additional magnesium. Priya in her slide said about giving magnesium. Do you recommend an additional EAR for the magnesium? You don't, right?
Not for all kids.
Yeah.
Not for all kids.
Yeah.
Like if we see that, if we can perceive that there is a deficiency, we'll definitely give
Only
it.
then, only
But
then,
not
right?
for everyone.
Yeah, the same thing
only
only
then,
even we
only
do
then.
follow. Wonderful talk.
Yes, we have to prove it. Like whatever
Yeah.
we do, we have to prove it, and we have to at least think in the proper line that, okay, why we are giving it. Not that, okay, just give it to everybody.
Yeah.
Even because even vitamin supplements have great adverse effects. If we give them in large dose, then definitely it will be affecting them, adversely, bad way. Too much vitamin is also bad. It will act as a
Hypervitaminasis
drug.
can happen. Yes.
Yes.
Thank
In
you.
few
Wonderful
cases,
section.
we have to deal with
Thank
these
you.
children
Thank
like
you so much.
normal growing children. We have to deal just
Yes.
little bit of changes and modifications as per the case. It cannot be a dictum or like the way
Exactly.
way we say that one size doesn't fit all. So it's for these population also,
Right.
I think. So now, autism, ADHD, and the dietary management. These are really so many internet-based wrong informations, myths, dietary facts, which are little unknown, half known. So really, thanks to Dr. Mandira Roy and Priya for highlighting the thing. And thanks, Lekha, for just concluding the thing, because you are vastly experienced in handling children for so many years. So I would like to extend my thanks from IPN Kolkata chapter for having this session, and we would like to continue with such different topics, unusual topics, so that like normal topics, we usually continue with normal topics. So we'll try to highlight different topics, and which will enlighten all the practicing dietitians, all the upcoming and budding dietitians for their practice. And again, thanks to Dr. Mandira Roy and Priya for sharing your thoughts and your inputs. And last but not the least, thanks to Mr. Shashank from Signutra for partnering with IPN Kolkata chapter. We look forward in future for partnering in such more interesting topics in our activities. Thank you so much.
Thank you, madam. Thank you so much.
Thank you, Mr. Shashank. And
Thank you,
others, if you can just switch on your video for a screenshot, if it is possible. Yes, Ifshita, you can continue.
No, nothing like that. Those who had to leave because of this numbers, really sorry from Kolkata IPN chapter. So in future, we'll keep it in mind so that we can have a extended numbers of attendance. So we can set up our system like that.
Okay.
Thank you, ma'am.
Thank you. Thanks a
I
lot.
really
Thank
want to
you.
thank you because, because first of all, because this is a very different platform. This is not at all where I hope my talk was relevant to you, and it helps you in your daily practice. And I don't know if anybody has any other question, I'm free to, communicate. Please communicate through mail or WhatsApp or whatever. Number is with Shomendu sir. And thank you. First of all, Priya, I'd like to thank, and for letting me share in her platform, I'd say, and Shomendu sir, obviously, and also the team of IPN, Ifshita ma'am, Shambhamitra ma'am, Koel ma'am, and also ma'am from Chennai. And thank you so much.
Thank you, ma'am.
Thank you.
To
Thank you,
join
everyone.
with us. Thank you, sir. Thank you, Ipsita ma'am, for giving. Thank you, Lekha ma'am, for giving me this opportunity.
Okay. Thank you.
Thank
Thanks
you,
a lot.
everyone.
So
Thank
we
you,
are going to-
everyone. And